Good morning, everyone. My name is Dr. Shafkat, and as you know, this is one more lecture, what you can say, for the thyroid. And what we have done before is how the thyroid hormones are formed in thyroid, and what are the different investigations which we can do to check the thyroid function function test. Okay, different test for structure of the thyroid gland as well as the function of the thyroid gland. Okay, so that was just the introduction for thyroid, and today we will move on to more clinical side for thyroid. And there are different conditions which can affect the thyroid. Okay, like there is Graves disease, which is a type of autoimmune condition, as well as there are different type of inflammations and different type of other conditions, like in which the thyroid can either overfunction and either hypofunction, or simply the formation of the thyroid hormones can be increased in the body, or the thyroid hormones can be decreased in the body, as you know, T3 and T4. And we have already discussed which one have the long half life and which one is more biologically active. As you know, like T4 is have a longer half life, okay, whereas T3 is more biologically active, right? And in peripheral tissues, okay, we know that T4 can be converted to T3 uh, whenever it is needed by the help of the enzyme deiodinase. Okay, so now, um, because we are going to discuss, what you can say, the more clinical side of thyroid. I will talk about the diseases later, but just to give you give you a concept, there can be two conditions. One is called as hyperthyroidism, okay, and one thing is called as hypothyroidism, okay. Like as the name shows, hyperthyroidism means, of course, when uh, the level of in thyroid hormones in the body will be increased, and clinically the patient is presenting with the features of like increased basal metabolic rate or different things. I'm going to give you a scenario, right, so that you can have a better understanding of this thing. The patient is thin and appears restless. Okay. The hands are sweaty hands. Okay. With Palmer erythema. Okay. What is this Palmer erythema? It is basically the hands of the patient. Basically, you can say look like more reddish. I'm going to show you a photograph of this thing as well. Okay. Simply, these are the when the hands of the patient become more reddish, and this is called as Palmer erythema. Erythema, as you know, redness, right? So anyone who have this Palmer erythema, what is basically it is due to hyperdynamic circulation. Okay, when the blood circulation in the body is hyperdynamic. Okay, uh, there are many conditions in which like Palmer erythema can occur. Okay, like one of that thing is hyperthyroidism, because there is hyperdynamic circulation going on inside the body. So this thing is there. Also, like on further examination, you will find tremors. Okay, tremors, as you know, what is tremors? So, uh, what we do, we ask the patient to stretch out the hands in front of the doctor. Okay, in front of us, and we see like if there is any fine tremors in the patient or not. If we cannot appreciate the tremors by simply looking at that, then what we can do, we can put a sheet paper, a paper on the hands and see like if the papers are moving or not, right? So the pulse is higher. Uh, of course, when the pulse is higher, so it should be more than 100, okay, or tachycardia simply. 100 per minute, of course, okay. And many patients, of course, like, they can present with atrial fibrillation as well. Like hyperthyroidism is one of the risk factor for atrial fibrillation. And that's the reason, like, many people who have atrial fibrillation, or many people who have stroke, for example, and whenever we found atrial fibrillation, we can check, what you can say, the thyroid hormones levels as well, okay. There is lid lag. I will explain you that in a while. And also lid retraction. Okay, now lid lag and lid retraction are basically, you you can they are not the signs of hyperthyroidism, but they point more towards the cause of that hyperthyroidism. For example, um, the patients who of grave disease, they have like extra fat deposition behind the eyeballs, and because of that extra fat deposition, what happens is like the eyeballs become protruded in front, okay. And what is the lid lag, by the way? When you we see anyone's eyes, so what we see is the sclera is hardly seen above the cornea and below the cornea, okay, because they are covered by our what you can say, eyelids. But anyone in who, like, whose lid, like, the upper eyelid is retracted backwards, so what you can see is like, you can see their sclera above the cornea, okay, in the neutral position when the patient is looking in front, okay, straight towards you. And that is called as lid retraction. And what is lid lag is basically when we ask the patient to look downward, okay. So what we can see is that we again can appreciate the sclera above the iris, okay. And it seems like, the patient have proptosis, like the eyeballs are protruded outside from the body, from, sorry, from the eye socket, okay. Okay. Many of the patients who have hyperthyroidism, they can present with proximal myopathy as well. What is proximal myopathy? Simply, the muscles, myo means muscles, okay. Pathy means, like, of course, there is some pathology. And proximal, like the proximal muscles, or you can say the muscles which are controlling your hip joint, around your hip joint, or the muscles which are controlling or which are present around your shoulder joints, okay. Like in many conditions, many endocrinological conditions, many carcinomas, many rheumatological conditions. One of the symptom which patients present with is weakness while getting up from the chairs, brushing their hairs, brushing their teeth. Why? If you will see that, when you want to try to get up from the chair without using the support of your hand, you have to put a lot of power um, in your in the muscles which are basically working around your hip joint, or especially when you brush your hairs, then what you have to do is you have to use the proximal muscles, or your shoulder muscles, okay. So this is proximal myopathy. And simply, whenever we want to check it in the patients, what we ask the patients to get up from the chair without using their arms, simply for the support, okay. And it is present in many patients who are thyroid toxic. Like hyperthyroidism means, of course, like the what you can say, the level of the thyroid hormones are increased in the blood, and this condition is also called as thyrotoxic, thyrotoxicosis. Okay, this is also called as thyrotoxicosis. So it is present. Proximal myopathy is present in many patients who have thyrotoxicosis. Okay, and this is believed that there is some disturbance in the muscle fibers because the what's going on in hyperthyroidism, because the thyroid hormones increase the respiration rate of all the cells in your body, and of course your muscles also have cells, and those cells have mitochondria, and that mitochondria are working more at increased rate, and there is more protein degradation in them, and there is more lipid oxidation. Simply due to that, there is some, like this thing, there is muscle weakness. Okay, by the way, this muscle weakness and proximal myopathy is not just the sign of or symptom of hyperthyroidism, rather it can be present in hypothyroidism as well. Okay, see, these are the features which can present in hyperthyroidism. Okay, and of course, this is like on examination what you will see, and the patient can present with symptoms of weight loss. Okay, uh, and this weight loss basically occur when the appetite, okay, of the patient is increased. Okay, so the patients complain like they feel more hungry, they eat more, but still they lose weight. Okay, on the other hand, when you will find other patients like carcinoma patients or any other patients, they do have weight loss but not increased appetite. Okay, so other things, there will be hyperthermia. Many of these patients, they present with, like, they feel their heart is, they are self-aware of their heartbeats, which is called as palpitations. Also they present with diarrhea. Okay, and also because their body temperature is increased all the time, so they cannot hold hot weather like normal people, so they are intolerant, you can say intolerant to heat, or you can say summers. Okay, so this is like the typical presentation of, you can say, the patients who have hyperthyroidism. Now, on the other hand, hypothyroidism, there are many other features. Like in females, there is a problem with their menstrual cycle, blood flow, and all this stuff. We will talk about that thing in a while. Okay. On the other hand, the hypothyroidism patients, because like hyperthyroidism, they lose weight, so the hypothyroidism patients, they gain weight. Okay, or simply when you will check their BMI, you will find that it is raised. Okay, uh, sorry guys, this is my first online lecture, so there will be many typos, and I am using just a simple word and a simple screen recording software. So I'm sorry, like, if you will see these things, but I'm going to fix it as soon as I will make more and more lectures. Okay, so now hyperthyroidism people, they appear restless, and hypothyroidism people, they appear slow. Okay, and their slowness is not just in their movement, rather you will see they are slow in speech as well. Okay, now they got dry hairs, you will found in them. They will complain of dry skin. Okay, their body temperature will be less, so you will found cool body or cool peripheries, especially hands and feet. uh, Pulse, when you will check, it will be slow. uh, like the way I am going is basically how we examine the patient. First we will do GPE, general physical examination. So whenever we do GPE, first of all, we always take general appearance look of the patient. So when you will see the patient, you will find that the patient is have increased BMI. They are very slow to move. When you will see their hairs or their skin, they will appear dry. Then of course you are going to take the vitals, so you will find that their pulse is low. And then we, of course, we start from the hands, we go on the face and rest of the body. So when you will go onto the face, you will not find any lid retraction or lid lag, because it is more present in hyperthyroidism. So many of these people, they have periorbital swelling as well. Okay, I'm talking about the patients of hypothyroidism. Okay, so why they have periorbital swelling is basically, you can say, because they have edema. Okay, or in this case we call this condition as mixed edema, uh, MYX, mixed edema. Okay, so they have what, periorbital uh, edema, and that is due to, around their eyes there is, uh, like below the skin around their eyes, they have deposition of glycose, aminoglycans. Okay, uh, also they have, what you can say, non-pitting edema. These guys have non-pitting edema uh, in the legs as well. Okay, so this is how they present, and collectively we call it as mixed edema. Okay, or pre-tibial mixed edema, because when we check the edema around the tibia, we found a specific type of rash. This thing is not just present in hypothyroidism, rather in many other conditions. Okay, like nephrotic syndrome and cardiac failure, things like this. So what you will found on like symptoms, when you will check the symptoms with the patient, you will found that the patient will complain of weight gain, increased sleep. Sorry, see, I missed this point over here. They will present with decreased sleep. Okay, so these patients will present with increased sleep, as well as they have diarrhea. So these people will be having constipation. Okay, and they generally feel tired all the time. Okay, and as you know, you can say the patients who have hyperthyroidism, they are intolerant to heat. So these people are intolerant to cold weather. So what happens, by the way, hyperthyroidism people, they prefer hot weather. Sorry, they hyperthyroidism people, they prefer cold weather, whereas hypothyroidism people, they prefer, what you can say, hot weather, because they cannot withstand uh, cold. Okay, when we check the reflexes, by the way, of these patients with hypothyroidism, what we found, that they have slow reflexes. I'm talking about ankle reflex and knee reflex, knee jerk reflex, and bicep reflex, and all these reflexes. So hypothyroidism people, they show uh, slow reflexes. Okay, so this is the clinical presentation of the patients of hyper or hypothyroidism. Okay, guys, now we are not talking about conditions until now, because right now I'm just telling you when the thyroid hormone will increase in the body, how the patients they present, or when the thyroid hormones will be decreased in the body, how the patient present. And there are different causes, of hypo or hyperthyroidism. For example, let me just tell you a few of the examples of or causes of hyper thyroidism. And then later on, of course, when we will start discussing the conditions, I will talk about them as well. Like the first one is like never forget this one, Graves' disease. Okay, why? Because this is very common in females. It's an autoimmune type of condition. Okay, now see, yeah, it is not like this that in all the conditions the patient will present with hyper, or like there is a condition in which all the patient will present with hypothyroidism. It goes somehow like this, that for example, there is a condition called as uh, like for example, there is infection to the thyroid. Okay, so as soon as the infection of the thyroid will occur, what will happen, that there will be inflammation of the thyroid gland. And once the inflammation is there, what will happen, that the thyroid gland cells will become leaky, and it is going to like all the thyroid hormones which are stored in the thyroid gland, they are going to spill out in the blood. So for the time being, there will be increased thyroid level, hormone level in the blood, and the patient will present with hyperthyroidism. But later on, when the uh, like the stores of the thyroid hormones will be exhausted, the patient will present with features of hypothyroidism. So, for example, okay, yes, one a very important condition. One thing is called as Hashimoto's disease. Okay, so now what happened in this disease is basically, firstly, patient have um, thyrotoxicosis. Okay, like or the features of hyperthyroidism will come, but later on, the patient will present with the features of hypothyroidism. Okay, so this is like one of the condition which like in the start the patient will be having the features of hyperthyroidism, and later on the patient will present with the features of hypothyroidism. There are many other conditions called as toxic adenoma. Like it's a small, you can say, size of adenoma, which is producing more and more and more thyroid glands. Okay, thyroid hormone. Sorry, there is one condition called as toxic multinodular goiter. You know what is goiter? Goiter is like when the thyroid gland size is increased. So we call that condition as goiter. Very common in females, by the way. And the thyroid is very much visible in front of the neck. And toxic means like it is a hyper functioning type of nodules which produce more and more and more thyroid hormones in the body. And the patient present with the features of hyperthyroidism. Okay. Then there are many other, what you can say, um, tumors, for example, which can present with increased thyroid hormones. And the tumors can be the thyroid, in the pituitary, anywhere. Okay, so other things which can cause increased thyroid hormones, one thing is called as decurvans thyroid thyroiditis. Okay, this one is like again inflammation of the thyroid, and most of the time this is associated with viral infection, and it include like it will lead to more and more thyroid hormones in the body. There is infections of thyroid. Thyroiditis or inflammation of thyroid can occur due to radiations, which in that case we call it as radiation thyroiditis. Okay, many females they get it after giving birth to baby, called as postpartum thyroiditis. And sometimes it is drug induced. In that case it is called as drug induced thyroiditis. Okay, so one of our important disease condition which we are going to cover today is called as Graves disease. Now, by definition, what is Graves disease? As I told you before, that Graves disease is a autoimmune disorder. And just like a general concept, guys, like all the autoimmune conditions are more common in females. And generally speaking, all the thyroid problems are more common in females than males. And as Graves' disease is an autoimmune disorder, so what happens in this one? There is auto antibodies, um, which are called as thyroid stimulating TSH. Okay, uh, there are auto antibodies to the thyroid stimulating hormone receptors on thyroid gland. Okay, so what is going to happen in this one? Like the body started producing some antibodies or autoantibodies which go and bind to the receptors on the thyroid gland, which are thyroid stimulating hormone receptors. And whenever like TSH, which is released by pituitary, it comes and it attaches to the TSH receptors on thyroid gland, the thyroid gland will start making more and more and more thyroid hormones, which is T3 and T4. So in this condition, these autoantibodies which are formed, they will go and attach to the receptors, and they will keep on stimulating thyroid gland, and which ultimately result into hyperthyroidism. Simply, Graves' disease can be defined as an autoimmune disorder which is characterized by autoantibodies to the TSH receptors of the thyroid gland, which ultimately leads to um, hyperthyroidism. Uh, what is the importance of this condition, or you can say what is the epidemiology of this condition? Is um, simply it is the most common cause of thyrotoxicosis. Okay, which means like all the people who have hyperthyroidism, one of the most important or the most common cause is Graves' disease, which is a autoimmune disorder. And the people who get this condition, mostly you will find them in the age of 30s or 40s. And as I told you, this condition is more common in females. And simply, female to male ratio is 7 ratio 1, which means like if you are going to find any patient in the clinics of hyperthyroidism, which will be diagnosed with Graves' disease, most of them will be females, okay? And most of them you will find that they are females. Um, there are different causes of this condition. For example, it runs in families, so we can say there is familial predisposition of this condition. Okay, so anyone who have close relatives who have Graves' disease, there are higher chances that they can also get Graves' disease. Okay, and you will find that these autoantibodies are circulating in their blood. Okay, and it all this condition have also some association with some genetic makeup, like if you know that MHC complex or major histocompatibility complexes, or which are also called as HLA, human leukocyte antigen HLA, B8 and HLA-DR3 are those who are have more chances of getting this condition. Okay, so and one general concept which I always tell to when I give lectures, that anyone who have one autoimmune condition, basically they are predisposed, or they have higher chances of other autoimmune conditions as well. So what are the common autoimmune conditions which you must remember is pernicious anemia, in which the intrinsic factor is not there, and these are the people who can get vitamin B12 deficiency disease, and one more condition, Hashimoto's disease, which I was talking about. Vitiligo is also one of them. Vitiligo, in which there is body like the skin get discolored. There is melanin is gone at some part of the skin. So there are different type of autoimmune conditions. Generally speaking, whenever anyone have one autoimmune condition, they have increased chances of other autoimmune conditions as well. So simply, uh, thyroid stimulating receptors, autoantibodies are formed, and what happens is like your immunity is the one which is playing role in this condition, and they are producing these autoantibodies which are going to the thyroid, and they will keep on stimulating this thyroid stimulating hormone receptors, okay, on the thyroid gland. And like there are some conditions, for example, whenever the patients they have certain conditions, like someone is taking steroids and they stop taking steroids, or someone have some viral or bacterial infection uh, postpartum, like after giving birth to the baby, like this immune response is triggered, okay. And I told you immune response is triggered in certain conditions, which I already told you. So this condition will become more evident in these patients. Okay. So one thing which I wanted to mention here is which must be remembered about Graves' disease. This Graves' disease do cause hyperthyroidism, but one of the thing which is this Graves' disease have special, like Graves' disease always affect the eyes, okay, or it causes ophthalmopathy, okay. So Graves' disease patients, they have some like a typical look. I'm going to tell you in a while what is that. And like there is more and more inflammation around the eyes, and under the skin there is accumulation of glycose aminoglycans, which I was talking about before as well, okay. And due to this extra tissue deposition, the eyeballs, they are pushed forward, so it seems like the eyes are propping out from the eye sockets, and it is called as proptosis. um, I can show you one of the photograph over here as well, which is in the slide of hyperthyroidism. If you can see over here how the Graves' disease people look like and how their eyes look like. Uh, so we can see, I'll show you. Um, wait, guys. Yeah, this one is like, but this one is like too severe condition, you can say, which I don't want to show you in the start, because that is like some sort of extreme condition. Uh, yeah, as you can see in this one, normally the eyeballs doesn't looks like this thing, but this female have her eyeballs are protruded from her eye sockets. Okay, so yes, this one is a good photograph, I think. See this one. See, the eyeballs are protruded outside. Okay, so this is lid retraction, lid lag. You can see all in one photograph. See, we can see the sclera above the cornea and below the cornea. Okay, it's look like her eyeballs are coming out. So this is one of the thing I wanted to show you. Okay, so I think too much time for this thing. Okay, so what will be the clinical features? Clinical features of this condition. Clinical features will simply signs and symptoms of thyrotoxicosis. Okay, so what are the signs and symptoms of thyrotoxicosis? One of the thing, thyrotoxicosis or hyperthyroidism. One of the way to remember this thing. I will show you clinical features. Okay. One of the way to remember that thing is by Thyroid, thyroidism. Okay, so T is for tremors, H is for heart rate will be increased, Y is for yawning. Okay, what is yawning? Yawning is like, when you feel tired you always yawn. Okay, so it means like these are the people who become fatigued too much. R is for restlessness. O is for oligomenorrhea or amenorrhea. Like in females, their menses are decreased or very much reduced. I is for intolerant to heat. D is for diarrhea. The other I is for irritability. S is for sweating. They have sweaty palms. And M is for muscle wasting or myopathy. Okay, so simply like these are the features. As you know, like hyperthyroidism, as I already discussed, like in my first lecture, which I was talking about, this thyroid hormone have effect on almost every cell of our body. And of course we cannot discuss cell by cell, but we can discuss by system to system. So on CVS, for example, it have many effects like tachycardia, atrial fibrillation, palpitations. Okay, on GIT, it is going to cause increased appetite, diarrhea, and weight loss. On what you can say, neurologically, they have proximal muscle weakness. Okay, females will be having oligomenorrhea, amenorrhea. Their skin will be having moist all the time. It will be warm. Okay, then there will be what you can say, proximal muscle weakness. I already talked about that. So eyes, in Graves' disease, there will be lid lag, lid retraction, proptosis. And due to this, like because their eyes are protruded outside, what happens is they have diplopia. What is diplopia? Diplopia is like double vision. Okay, because we see the vision as everything as one because our eyes are well coordinated. But when our eyes are protruded outside, this coordination is disturbed, and that's why they have diplopia. Okay, they see everything double. Okay, so these are all the features which will be present in Graves' disease, or you can simply say that there will be all the feature of thyrotoxicosis. Okay, now because of their thyroid is working too much or hyper functioning, so maybe you can found that they will develop a goiter, which is the thyroid size is increased, and the blood supply to thyroid, the big thyroid, will be increased as well. And due to this increase, maybe when you will examine the thyroid and if you will auscultate the thyroid, you are going to hear, due to increased blood supply, a bruit, which we call it as thyroid bruit. Okay, which is due to increased blood supply. Auscultate. So on auscultation, you are going to see thyroid bruit. And as I told you, whenever it is Graves' disease, guys, do always remember, always remember that it gives ophthalmopathy. Okay, what are the signs of ophthalmopathy? What you will see, you will find proptosis, and I told you they may have diplopia. Okay, due to this, the photograph I show you, the extreme one, because their eyes cannot, like their eyelids cannot cover the eyelids eye properly. So because of dryness, their cornea can get damaged, or they will be having corneal abrasions. Okay, there will be increased deposition of glycosaminoglycans under the skin around the eyelid, so it looks like swelling. We call it as periorbital puffiness. Okay. And yes, of course, the regular stuff, which is lid lag, as well as lid retraction. Okay, which is very important to remember. Okay, so like these are all the signs which you're going to see in the eye, and guys, this is very important to remember as we are studying right now Graves' disease. So many of these people, because of this glycoaminoglycans deposition around the eyes, it's an autoimmune condition. Like there is what you can say increased deposition of this thing around the skin in front of the tibia. We call it as pre-tibial MIGS edema, which I already explained you previously, right? Their skin become thick, okay, the dermis, and this one is non-pitting type of edema. You know, Guyton explained edema in a best way, and when I was in medical school, and I always talk about Guyton. If you want to be a good doctor, you know, you have to master Guyton first. So Guyton talk about edema, type of edema, pitting edema, non-pitting edema. So this is one of the cause of non-pitting edema, uh, like in which like there is no pitting is there. One more thing which is not present in all the patients, but it can present in many of the patients is called as acropathy. Okay, so what is acropathy? As the name shows, acro means like, you know, this fingers and all these things. You know, these are the people who have clubbing. Okay, and their digits become thick. Okay, you can see over here. Maybe I have a photograph of acropathy as well. um, I can show you. Yes, this one. See, their fingers become thick. This one is a photo of palmar erythema. See, redness in the palms. You can see over here. And this is a photograph of pretibial myxedema. Okay, I can make it large for you. You can see this one. Then this is palmar erythema due to hyperdynamic circulation, and this one is thyroid acropathy. Okay, we can also do X-ray of these thyroid acropathy just to see why this one is there. Okay, as I told you, so the after clinical features, what comes is investigations, and what investigations we do. We had a great discussion on this thing. The first best test to do is what? TSH levels. So it is hyperthyroidism. The thyroid is stimulated by autoantibodies, which means no matter the thyroid stimulating hormone is present or not, those autoantibodies will keep on stimulating the thyroid gland. And as those autoantibodies will keep on stimulating the thyroid gland, the T3 and T4 will go back to pituitary and will give a negative feedback, okay, and the pituitary will stop making TSH, so the TSH level will be low. But no matter the TSH level will be low, the thyroid is not working under TSH, rather thyroid is working because the autoantibodies is stimulating the thyroid continuously without any feedback from pituitary, or without depending on TSH, okay, because the autoantibodies are stimulating thyroid and they don't care about the TSH level, but the TSH level will be low. If you are going to check for T3 and T4, okay, T3 and T4. Clinically, by the way, guys, we always check T4, or what you can say. I already told you, it is present in two forms. One is free form, one is bounded form, bounded with proteins. Okay, so we always check T4 level, which is free. What you will found, it will be raised. Okay. T4 have longer half-life. Okay, T3 have less shorter half-life. but T3 is more biologically active and T4 is less biologically active. So, see, now it's autoimmune condition. What are is the investigation which will tell you that this is grave disease? You are going to check the auto antibodies in the blood, okay, and what you will found that there will be thyroid stimulating antibodies, okay, TSIs in the blood you will found, and this is very specific test for Graves disease. Okay, not so sensitive but very specific. If you will do radioactive iodine uptake test, what you will found? Definitely thyroid is hyperfunctioning. It will be increased. Thyroid will be taking more and more iodine inside to produce more and more thyroid hormones. Okay, so like this is the investigations which we do um, to check for like either Graves' disease is present or not. So, how we should treat this condition? Okay, the treatment of Graves' disease. Okay, after of course investigation, we must go for treatment. Okay, okay. So, see, if someone have hypothyroidism, for example, his thyroid is not functioning well. So, what we have to give them? Very easy. We must provide them with thyroid hormone that is called as thyroxine. But if someone thyroid is hyper functioning, so what we have to do? We have to stop the production of thyroid hormone. In this case, what is given? Remember the name of two drugs: propyl thiouracil, okay, which is also called as PTU, and the other drug is methimazole. It is also written as MMI. Okay. Now these two drugs are the drugs which basically stop the production of thyroid hormone. Like they inhibit the synthesis of thyroid hormone um, by inhibiting some enzymes. Okay, by inhibiting the combination of iodine inside the thyroid gland, okay, of course by the help of some enzymes, peroxidase, okay. uh, so both of them, they can stop the production of thyroid hormone inside the thyroid gland. um, the good thing about PTU, propyl thiouracil, it also stops or inhibit um, peripheral what deiodination. Okay, so as like I explained this point many times, what is that? Simply, it will stop T4 to convert, okay, into T3. Okay, so simply it stops in the peripheral tissue. This drug stops the conversion of T4 to T3. Okay, so whenever anyone have Graves' disease, what we do is basically we put them on these two drugs or one of these drugs, um, and until the thyroid hormone levels come back as normal. And TSH is the best test, guys, to check for either the treatment is functioning or not. Okay, so we have to continue this treatment for around 6 to 8 months until the thyroid hormone levels they come back as normal. And when we give the treatment for 6 to 8 months, so of course you must know the side effect of these drugs as well. Like most of these drugs um, causes hepatitis and rash. Minor side effect is rash. Okay, so anyhow you can check the side effects in pharmacology books like in detail. So this is one of the thing. Okay, other drugs which if we have to give someone with MMI only, which doesn't have any action in the periphery, there are some other drugs like sodium iodate. Okay, is one of the drug. It have the same function, which is this one. Okay, so like if you want to put anyone on this drug, methimazole, so what you can do, you can add it, you can combine these two drugs, okay, to which will achieve the same function which propyl thiouracil is doing alone. Okay, so this is one of the thing. uh, uh, Methimazole is preferred, you can say, over PTU, because this one have the longer half-life or longer duration of action. You don't have to go in this details, these are clinical details. Like the dosage of methimazole is just once a day, but whereas PTU you have to give on multiple times, like 2 to 3 times every day. So like more user friendly, you can say. Okay, so one thing which I always tell, and it's a very important questions when we come to different exams like PLAB and USMLEs, what we you choose should choose in pregnancy. Or okay, so remember, P is for pregnancy and P is for PTU. Okay, so PTU is a good drug during pregnancy, especially the first trimester. Okay, when of course the different organs are formed, so we give them PTU because PTU is less teratogenic, or it doesn't cause any harm during the first trimester of the pregnancy. In second or third trimester you can give any drug, you can give this or you can give MMI. Okay, so first trimester PTU should be given. You can select any drug like PTU or MMI in second trimester onwards. Okay. Okay, this is the medical management of to stop the hormone, and many of the side effects is sorry, many of the symptoms of thyrotoxicosis is increased heart rate and things like this, which are the symptoms of whenever like there is sympathetic nervous system is activated. And what we do to block sympathetic nervous system actions, we can also give them beta blockers, okay, which will give a lot of symptomatic relief to the patient. Okay, if the condition is not managed medically, then of course what we do, we go for surgical options. Okay, so what are the different surgical options which are available? Like a very common sense, surgery, it's surgery. So you can go for thyroidectomy, but before that, nowadays they are doing some new type of therapy that is called as thyroid ablation therapy, like in which the thyroid cells are destroyed, you can say, with the help of radioactive iodine. I is for iodine, and it is 131. Okay, of course this 131 should be like this. Sorry, 131. So this 131 should be like, oh sorry, okay, should be like this. So what happens if PTU or MMI is not working? So we can give them radioactive iodine 131, which basically destroys the thyroid gland. Okay. Oh. I'm sorry, guys. Okay, so which basically destroy the gland. Okay, and once the gland is destroyed, so what will happen? It will hypofunction. The patient now will go into hypothyroidism, which can be easily managed by giving them, providing them with that hormone in the form of tablets, thyroxine tablets. Okay, if this treatment you don't like, or For example, if the patient is pregnant, because in pregnancy this thyroid ablation therapy is contraindicated, then you can go for conventional surgical options, subtotal thyroidectomy. Okay, in which what happened, like they are going to remove the thyroid. This is a very good therapy if you are suspecting that the patient has carcinoma as well, for example. So uh, this surgery can be done. Okay. In grave disease, one of the treatment which is very, very, very important, as I told you, there are different. There is ophthalmopathy. Okay, so how we can treat that? First of all, we ask the patients to stop smoking or smoking cessation, um, because their eyes can dry, because their eyes cannot close properly. So we give them eye drops to prevent drying. Okay, and this is due to autoimmune condition. So what is the treatment of autoimmune condition? We give them steroids. One of the steroids which we give them is prednisolone. Okay, if the condition cannot be solved by this thing, we can give them radiations or orbital radiations. And the last resort, if someone eyes cannot be treated by all this way, then surgery is done to remove extra tissue below the eye. Okay, so simply, this is all the treatment which is given to the patients, and many of the patients, they're like their condition is resolved by the drugs. Some need surgery, some need radioactive ablations, things like this. Okay, many of the people, they have Graves' disease, and sometimes the Graves' disease goes by itself, but just in few cases, sometimes it goes but it comes back. So simply you can say there is a relapse. Okay, so that's all about Graves' disease. Hope you enjoyed this lecture, and I am going to prepare more lectures during this week and keep on uploading for you guys. Until now, bye bye.